Hi, my name is Bill Hucker, and I am a cardiac electrophysiologist at Massachusetts General Hospital. And I'm here today to talk to you about rate versus rhythm control for atrial fibrillation. So the key takeaways for this talk are to review the appropriate considerations of when choosing rate versus rhythm control for patients, to identify patients that may benefit from rhythm control. We'll review how indications for rhythm control have evolved over time, and identify the pharmacologic and non-pharmacologic methods for rate or rhythm control. To start, I just want to say that atrial fibrillation is highly prevalent. It affects anywhere from 6 to 8 million Americans currently, and that number is projected to increase over the next decades because of the aging population of the United States plus the obesity epidemic. And AFib adds billions of dollars to the healthcare system in the United States, and therefore it's an important problem to diagnose and to treat. And it's important also to know that the one-year mortality after an AFib diagnosis is up to 25% in the Medicare population. This was data from a study in 2012, greater than 400,000 AFib patients. 55% of them are women with an average age of 80, and you can see that the mortality 1 year after AFib diagnosis reaches 25%. So this is a very prevalent condition with a significant morbidity and mortality. Treatment for AFib is often divided into three main categories. One is thromboembolism prevention, preventing strokes. We won't talk about that in this particular talk. And then there's the decision about considering rate control versus rhythm control for patients. And there's a number of factors that would favor one strategy over the other. For rate control, a patient who has never had heart failure, if they're significantly older, if they have persistent AFib and they've been in it for a long time, if they've failed prior rhythm control strategies, or if it's their preference, and if they have minimal symptoms, all of those things may favor a rate control strategy in patients. However, for rhythm control, patients that have had heart failure in the past, or CHF, if their AFib is paroxysmal and they're early in the disease, if they're symptomatic, if it's newly detected, if it's their preference to stay in normal rhythm, all of these reasons are good reasons to pursue a rhythm control strategy to begin with. In terms of options for rate control, there's nodal blocking agents, and these include the calcium channel blockers, beta blockers. I would encourage you to think differently between selective beta blockers and non-selective beta blockers. Sometimes the non-selective beta blockers achieve a little better rate control in my experience. There's also digoxin, which is a little bit fraught in some patients, but certainly it's an option when rate control can't be achieved with the other two options. There's antiarrhythmics. Antiarrhythmics are usually used for rhythm control. However, I just want to mention that both amiodarone, dronedarone, sotalol, these drugs have some beta blocking properties and therefore provide some rate control as well. But I wouldn't use them just for rate control. And then there's a non-pharmacologic method, which is a pacemaker and an AV node ablation. And that's a permanent solution to rate control. It obviously makes the patient dependent on a pacemaker, which can have its own issues down the road. But there may even be a mortality benefit with this strategy, which was recently shown in the APAF-CRT trial. In terms of rhythm control strategies, there are antiarrhythmic medications. These are often divided in the Vaughan-Williams antiarrhythmic classifications of class 1, class 2, class 3. The class 1 agents would be flecainide or propafenone. These have to be used in conjunction with a nodal blocking agent. There's also class 3 drugs, sotalol, dofetilide, amiodarone, dronedarone. All of these medications can provide rhythm control as well. And then there are non-pharmacologic methods for rhythm control, which would be an electrical cardioversion. Sometimes the effect of that is temporary, but sometimes patients get a significant benefit for a long time out of that. And then there's catheter ablation. In terms of other strategies to help with rhythm control, I think it's important to mention that weight loss, alcohol avoidance, and management of sleep apnea can all improve patients' rhythm control and decrease the amount of time that they spend in AFib. Now, you can't have a discussion about rate versus rhythm control without mentioning the AFFIRM trial, and that's because the AFFIRM trial really dominated the thinking about rate versus rhythm control for a long time in this field. This was a trial published in the New England Journal in 2002. It randomized 4,000 patients to either rate or rhythm control, and the net endpoint was looking at mortality, which showed no difference in mortality or strokes at 5 years, after 5 years of follow-up in these patients. And so the take-home point of this has been for years that really the main reason to pursue rhythm control is because of symptoms for patients, because it really didn't have a mortality benefit in this trial. I think it's important to realize when you're thinking about the AFFIRM trial and those results is to think about what their options were for rhythm control at the time. This was published in 2002. It had 5 years of follow-up, and that means that the study was mainly conducted during the 90s. And the rhythm control options then were really medications. Catheter ablation wasn't an option at the time. The most common rhythm control medication used was amiodarone, and that was the main drug that was used to start rhythm control, with the second one being sotalol. And then many of the other drugs are no longer even available now. And so when thinking about the rate versus rhythm control outcome of that trial, it's also important to remember that antiarrhythmics, and those in particular, those drugs that were used, amiodarone and sotalol mainly, have waning efficacy over time. This was a trial that was in 2005, and it looked at the likelihood of patients staying in sinus rhythm on either sotalol or amiodarone. And it showed that after 3 years, even the most effective drug, amiodarone, had less than a 50% number of the patients stayed in sinus rhythm less than 50% of the time on amiodarone. So when thinking about AFFIRM, having rhythm control strategies that weren't incredibly effective, taking those patients and looking at rate versus rhythm control over 5 years, it's really not surprising that there was no significant difference in the outcomes between these two strategies, because the drugs weren't that effective to keep patients in normal rhythm. So fast forward a number of years to more recently, and this was a trial that was published in 2020 called the EAST-AFNET 4 trial, and this was looking at the same question, rate versus rhythm control, with the caveat of looking at early rhythm control to see if patients benefited from early rhythm control with long-term outcomes. And the outcomes that they measured were stroke, hospitalization for heart failure, or acute coronary syndromes. And in these patients, they found that early rhythm control, which was defined as they had AFib for less than 12 months, and patients had a median of 36 days in between when their AF was diagnosed and when they were enrolled in the trial. And randomizing patients to early rhythm control meant that long-term there was a decrease in the primary outcome, which again was death, stroke, and hospitalization from heart failure or ACS. So this argues that intervening early for AFib and trying to maintain rhythm control early may have long-term benefits for patients down the road, regardless of symptoms. I think it's also important to mention that there are adjunctive therapies for rhythm control, specifically weight loss. This trial was from Australia, and they intervened to allow patients to have a sustained weight loss. And patients in this trial, the patients that were able to maintain 10% of their body weight loss, had about 50% of them remained AFib-free after 5 years in the trial. That's just with weight loss. And I put this graph up that I showed before, which is amiodarone, sotalol, and looking at maintenance of sinus rhythm with these drugs. And you can see that weight loss was just about as effective, if not more so, than amiodarone in follow-up to maintain freedom from AFib for these patients. So I think that that's an important message to relay to patients. So in conclusion, AF has a significant morbidity and mortality, and it's a very prevalent condition. Rhythm control can be difficult to obtain, but it certainly has benefit in certain populations, for instance, in symptomatic patients or in heart failure. Early rhythm control may have benefit in patients with a CHADS-2 VAS score of 2 or greater in terms of long-term outcomes, and antiarrhythmic efficacy wanes over time. Thank you for your time and your attention. I hope you found this video educational.